So welcome. Very shortly we're going to have Dorcas's introduction, which has been pre-recorded. So what we're going to do today is this is the Health and Care Across the Life Course theme meeting. So if you thought this was equitable place-based health and care, you're in the wrong room, but you're better here. So, Dorcas is going to give a general quick update to the theme and where we're up to and some sort of highlights. Then Clarissa, who you heard earlier, is going to give a different brief talk about where we're up to in the older adults theme. And the reason we're giving that a short time is because she's got far more work than she knows what she can do with already in the older adult theme. So we feel that's really well developed and it's generating its own work. It's got a huge momentum, so we don't really need to do more in that. But if you want to join in with the work on dementia and older adults, Clarissa's over there. She's very happy to hear from me. We also have the Liverpool forum, which she'll talk about briefly in her talk, where you can find out on a regular basis what's happening in that theme. So just going to get 5 minutes. Then we've got 4 PhDs and interns talking about the work they're doing in our theme. Those will be brief talks. Then I'm going to do a quick chat about the business plan and a change that I want to make in our theme. But I want your feedback on that and your accession for that. Then Dorcas and Joe are going to do 20 minutes on the children and families sub-theme. Paul has recorded something on adolescence, particularly in mental health in adolescence. 15 minutes, and I'll do with Joe, a bit of panel work on that afterwards to see what other ideas are having. Then Kathy Montgomery, who's online, and will be doing something on marginalised group for 10 minutes. I'll be doing 10 minutes with Rob and Ben, who's going to be doing something around the health and well-being and retention with the working age, which is what I'm doing, but then we're also doing something around art and mental health, I think it is, isn't it? And we're going to be talking about access to physical recreation and how that can help your health. And then we'll have a final thoughts and close. So the purpose of today is to get your feedback on our program and ideas, and it's like it was this morning, because we'll be using that to inform our themes plans for the business plan that we're doing for the 18-month extension. But what we need to know is not just what your interests are, but what you actively want to get engaged with and how you want to work with us, and if you're working with anybody else that we should be knowing about on those topics. I will now sit down, and if you can start, Dorcas, please.
Good afternoon, everybody. My name is Dr. Sakeju Obi. I'm a public advisor for Health Care Across Life Course and also a co-lead. As you can see me there at the bottom. In our team, we've got six of us. We've got our team lead, and I'm Director Mark Abdi. We've got Manager Shanghai. We've got Clarissa, team fellow, and we've got Paul, who is our public advisor, as well as the deputy co-lead, and also Joe Blair, who is also our co-lead. If you want to find out more about them, please go on our website. Next slide, please. We work in from pregnancy down to end of life. And you can see our sub-teams, family and children. And myself and Joe, we look into family and children. Adolescents, Paul is interested in the youth, and he does a lot of boxing with the youth. Working age adults, Mark is interested in that. Older adults, our team fellow Clarissa is interested in that. And then the cross generation is bringing the family and children back with the elderly as well. So we're trying to do that. And the marginalized group, we work with the public as a manager, because they have a lot of groups that are marginalized as well. Thank you. We've done a lot of projects. Our total projects include all projects of 128 really. And all the projects have been submitted, funded, not funded, or at scoping stage. I've got PhD and interns, the 4 done projects. Next slide, please. Thank you. We have got a number of papers that have been published for the last 4 years. Even during the COVID, we were trying to publish papers. thanks to Clarissa. And what we've done now is that we're sliding down a bit. Hopefully we catch up soon. Some of our papers have been cited in some publications, but it depends on if they're interested in what we're delivering. Thank you so much. Next slide. We've got national projects, priority projects, and a lot of projects on dementia and elder people. If you go on our website, you will see a lot to do with that, and you can read about that. And we have community resource to improve the strength-based approaches and national audit of social care and social work, linking it into the dementia and the older people. And also we got this other projects as well, that integrated social care in response to intimate partner violence and abuse, supporting adults and children victims. And it's called VISTA. This project is very wide. It's for 5 acts that are involved in it, from Kent and Essex down to Northwest Coast. National Act Social implemented a project. This is a good one. Digital technologies to support community dwelling in older adults and receive of social care and their carers. And this is another good project. But you can read about them later in our website, on our website. Thank you. We have got 30 members, more than 30 members, and we want more, and we want to work with you all. So if you've not been involved with us, we want you to be involved. We want to put our research into practice. So that's important for you to be involved, and tell us what you want us to research as well. Next slide, please. And this is Research Development Networks. It's a good network. We've got about 4 of them, really, about 3 are mentioned here. And we do social prescribing, which is the hot potato now for people if you don't want tablets. Social community mental health and well-being, very important. And the seaside and community is very important. I've got so much to say, but I've only got 5 minutes. So I must say thank you so much for listening to me. And if you want to read more about us, please visit ACA on Arc Northwest website. Thank you.
Right, you hear me again, but this time about something else, so I hope that's all right. Thanks for the 5 minutes. I thought now in this theme meeting to share some opportunities for involvement as opposed to showcasing some of the research that's ongoing. So there's a number of different ones I'm going to show you now. One is has just received my email inbox a couple of weeks ago. I can't say too much detail because the final confirmation from NIHR is still outstanding, but we're involved with a large research grant led by another university, together with other universities and organizations, on dementia and neurodegeneration. But one of the really interesting and more, I suppose, innovative things as well, we're already having public advisors on all of our research, but this has costed in lived expert researchers, so they will be employed 1 day a week for 3 years. For 3 people will have that, so we can employ a person living with dementia, a caregiver, etc. And we have 3 of those posts. So in the next few months they will come out. They can be based at University of Liverpool in the office with our team, etc. But it's a really nice way of not just having the standard researcher, but really the lived expert helping us with data analysis, interviews, etc. So keep an eye out if you're interested in this. Okay. Another opportunity, and obviously I'm going to use the minions, is we're going to put together a grant application for the recently announced Alzheimer's Society Doctoral Training Center. Still early stages, but we've got some of our organizations together, and we're putting this together from an academic point of view already, because we want to build those next really happy-looking PhD students and not the wacky postdocs or the emeritus profs. We want those good PhDs in the Northwest region looking at dementia. As part of this application, we want to involve, as always, people with dementia, unpaid carers, people working in third sector, healthcare professionals to help shape this. It's not just us universities who are putting this together. We want everyone involved, like we do in the ARC, like we do in all of our research. So if you're interested or know someone who wants to get involved, I can already see someone nodding their head viciously. So please let me know, okay? And it's a fantastic opportunity, again, to build capacity in our area. Another thing to highlight, one of our recently appointed NIHR postdocs will be submitting her ethics shortly, and Dr. Megan Reedman is looking at hearing loss and Parkinson's disease dementia and Lewy body dementia. So she will be conducting some interviews with people with Lewy bodies, Parkinson's disease, etc., probably starting from October onwards, depending on ethics. So I'm just going to flag it up now, because it is quite a smaller population, difficult population to recruit from. But again, if you know anyone, etc., please get in touch, and Megan is sitting up front as well. And then, as Mark was mentioning, the Liverpool Dementia and Aging Research Forum, we've got a lot of events coming up. The next webinar will be featuring Professor Bianca Brishnath from Australia, because she's a really good expert on cultural diversity and dementia, and using media and videos, etc., to increase understanding of dementia in different population groups. So it'll be really interesting to hear from her in the forum. We've got networking meetings as well, etc. So again, get in touch if you want to be involved. It's like a mini ARC just on dementia. And we have our 5th annual conference. 5th, there's quite a lot already we've done. It will be held at the Liner Hotel on the 25th of October. Registration is open now. We've already received quite a few abstracts, which is closing end of this week, but we might extend it by a week or two because of annual leave. We have 2 keynote speakers confirmed, Professor Claudia Cooper from Queen Mary University in London, but also private eye cartoonist Tony Husband, who has written and drawn the cartoons of 2 books on dementia, living like of his father's dementia journey. So again, if you want the links to that, it's on our webpage. And that's me done. Thank you.
Thank you. That's very impressive, because unlike me, your mind doesn't go blank as soon as you stand up here. So we've now got 4 presentations. Thanks, Katie. Some of which are recorded, some of which will be live. I think the first one's a recording, isn't it?
Hi everyone, my name is Tony Hall, and I am a new NIHR funded PhD researcher working out of Liverpool John Moores University. I sit within the Health and Care Across the Life course theme and the Older Adults sub-theme, and today I'm going to give you a brief introduction to my research, which is looking at evaluating the feasibility of installing visual adaptations into the homes of older adults to prevent falls. So why are falls important? We know that 1/3 of people aged 65 years and older fall each year, and this risk increases with age. Falls can result in injuries such as fractures, which can lead to long-term hospital admissions and even care home admissions, and this can cost around £2.3 billion annually in the UK. Now, while exercise interventions have been shown to increase muscle conditioning and improve stability, they are not always effective or accessible for older adults. We also know that most falls occur in the home, and more than 30% of these falls are caused by environmental hazards. So when considering that most falls occur within the home environment, what about older adults from a lower socioeconomic background? Research suggests that typically this population are more likely to have poorer housing stock, which has previously been associated with a higher risk of falls. Home adaptations are not always feasible for this population, and low income can mean that inadequate or delayed home maintenance can lead to more environmental hazards within the home environment. So this brings me on to our intervention. My colleagues at Liverpool John Moores University have shown that low-cost visual adaptations can decrease falls risk. Visual cues, such as the horizontal vertical illusion, were shown to increase foot clearance on steps and stairs, and also lower height hazards such as door thresholds, which from an online survey were shown to be areas where our older adults were falling within the home. Research also showed that using optimal lighting, such as high-powered LED light bulbs above stairways, can reduce that riskier stepping behaviour. However, These studies were only conducted in a lab environment, so this PhD now wants to take those findings and implement them into a real-world setting. So what are our research questions? We want to know whether it is practical to install visual adaptations into the package already prescribed by falls experts. We also want to find out whether the visual adaptations will be accepted by older adults from areas of lower socioeconomic backgrounds, and whether these visual adaptations affect habitual activity. So why me? Why do I want to do this research? So I graduated from Wrexham Glyndŵr University with a psychology degree, and I then went on to study health psychology at Manchester Metropolitan. Now, it was during my Masters that I was introduced to falls prevention as a research area, so decided to look at the impact of the COVID-19 restrictions on older adults who fall. It really opened up my eyes to the work that needs to be done in this area, and also gave me the understanding that falls are not just physical. There are also psychological factors that contribute to falls as well, such as anxiety and fear of falling. My health psychology background has also given me experience in behaviour change and risk perception, and by combining all of these different perspectives, it can lead to better outcomes for falls prevention research. I also have some industry experience. I worked in the NHS and had a position at UCL. Now, these studies were embedded in health inequalities, and it really opened up my mind to how something so simple as where we live can massively affect our health outcomes. And my experience with the qualitative methods means that I can help to drive forward research by really helping to gain those lived experiences of the population. So that's it from me today. If you'd like to find out a little bit more about how we're going to conduct the study, our poster is being showcased here today at Arcfest, and here are my contact details if you would like to get in touch, and also a QR code for the references from the presentation. Thanks for listening.
So, Kim Ward is our next presenter.
Yes, okay. I'm Kim Ward. I'm Dementia Project Coordinator at the Brain Charity based in Liverpool. I've been working with health and care across the life force for a little while now, but with Clarissa Giebel and Megan over there. So I was taken on as Arc Northwest Coast research intern, and I just want to say actually this is a really great opportunity if anybody wants to kind of promote it. It is really, it's taught me a lot already. I've only been there for 3 months, so yes, this is going to look like less advanced research than I think you're used to seeing, but we're on the way. So I run Music Makes Us, which is music-based therapy for people living with dementia. We run it in care homes, in community centres and in daycare centres. And we've worked 2 strands, really. The first strand is dance and physiotherapy. So physiotherapists have worked with dancers to set the routine. Speech and language therapy and singing is the second strand. Likewise, a speech and language therapist is on the ground in all of the sessions that we run. We run them in blocks of 12, so we go out into the care homes or into the community and set up these sessions. We do the PR first, and then we kind of run them. We have been running since 2018. I think those numbers are actually too low by now, but we run them in the wider Liverpool area. So I probably don't need to convince anybody in this room about why music-based therapy is really good for people who are living with dementia. I mean, what we see, you know, every single session is the possibilities of communication are huge, where just kind of passive music kind of intervention in the care home is way less important, but active, you get people singing, we get people dancing, we get memories provoked, but also we do have these 2 underpinning therapeutic strands as well, which are coming through. So, like I said, we run them in different places, and over the course of the sessions, we've seen that take-up is really different in the community, it's really different in care homes, and it's really different in daycare centres. Care homes can be a little bit more stable, obviously, because there's a lot more support there to get people to the sessions. In the community, it varies wildly depending on what community centre, what the underpinning kind of resources are of that community centre. And obviously daycare, it's I'd say a little bit more chaotic in terms of uptake. But what we're really interested in is trying to figure out what are the barriers and facilitators to the access and also to the implementation, so that we can go forward and start to propose, based on the research, different kinds of strategy for different places, right, which would make sense. So this is the research part, which is the new part for me. I'm not going to read all of this out, but it's a one-year project. I'll be doing semi-structured interviews with a little team of people, about 25 people who we've already worked with as part of these music interventions, 5 of whom will be people living with dementia, 5 carers and 10 carers, sorry, and 10 organisers. If anybody's got any hot tips on methodology, come and see me afterwards and give me some advice. I'm very happy to receive anything. So we're going to kind of use these outcomes to develop conclusions, recommendations to take into the service provision, we hope, in the Brain Charity. And obviously, of course, our kind of participation and collaboration in our North West Coast is also upskilling us at the Brain Charity, so we can pass this information about how we do research and how the outcomes of research can kind of go forward into our different service provision. That's a wonderful opportunity for us to have. That's the end of the... Thank you.
Because of time, we'll take questions from London from one to the next. So.
Hello, my name is Madhavi Seshu. I'm an orthodontist treating children and adults with a cleft. 1 in 700 babies are born with a cleft every year in the UK, and Meet Nathan was born with a cleft on the right and the left side, and he attended more than 100 healthcare appointments for his treatment from when he was a baby till adulthood. So you can imagine what the burden of care is for these families. The Older Hay team covers many deprived areas in the Northwest, including Knowsley, Liverpool, Blackpool. And this is a small piece of work that we carried out looking at children with cleft and their dental treatment. Each dot represents a child here. The green dots are children who've been assessed and treatment has been done. The orange dot where the children have been assessed but the treatment has not been done. And the red dot where no treatment has been done and no assessment has been done. And we arranged this according to deprivation. And what we found was, least deprived category, whatever the treatment was, it has been assessed and treatment has been done. But in the most deprived category, we have many red and orange dots. And this is not unique just to dental treatments. So my question is, what are the barriers to accessing dental treatment for children with a cleft after assessment by a specialist in children's dentistry? My internship started on the 1st of April 2023, and I'm using a qualitative research methodology interviewing parents of children with a cleft. My concentration today will be on PPI in the first 8 to 10 weeks. My PPI contributors have helped me to frame the question, what is important to parents and patients? Give it a real-world context, and my funding is by Older Hay Children's Charity. For example, the information sheet and the consent form that I developed, I sent it to my PPI contributors with the original title, Social and Health Inequalities in Access to Dental Care for Cleft, which is a perfectly good title, but they got back to me to say they didn't actually understand what the research question was. So we changed it to a simpler title, Barriers to Access for Dental Treatment for Children with a Cleft, and we QR coded it as well. Another suggestion was, could we use AI to make the language simple and clear? with a reading age of 9 years as gov.uk suggests. For example, a line in my information sheet read, the interviews will be voice recorded only and later transcribed, and audio recording will be deleted. How could a 9 or 10-year-old understand what transcribe means? ChatGPT suggested, I will record your voice during the interview, later write down what you have said, and then delete the recording. And I found ChatGPT very, very useful and user-friendly. My two focus groups are one with the Cleft Lip and Palate Charity Organized Group, which gives it a wider perspective, and the second one with young adults with a lived experience of cleft. Lived experience being the key word here, and this would add very much to my research. One of my PPI contributors, whose first language is not English, suggested that I could use a visual aid in addition to written word and the audio recording. So I looked into it, and we are now doing visual minutes for the focus groups to develop a topic guide which is visual, and a leaflet at the end of research, which is again has more of a visual clue rather than the written word alone. So in my first 8 to 10 weeks of research, the impact of my PPI contributors has been that making research work for everyone, since my research is social and health inequalities, giving it the real world context. And I used innovation and technology to help me achieve this. And I'm hoping in the next few months, I'll learn much more from my PPI contributors. It has been a very, very positive experience. Thank you so much for listening today.
Hi, my name is Dr. Sharuk Methahel. I'm a consultant in paediatric emergency medicine at Alderhay Children's Hospital in Liverpool, and I have the honour of being an ARC intern, and this is my project. It's called the Sporty Study, which stands for Sport Rehabilitation Following Trauma in Young People. It's well documented that children and young people who engage in regular sporting activities have multiple health, well-being and academic benefits, and sport is key to preventing obesity, heart disease, type 2 diabetes and cancers later on in life. But sport isn't without risk, and there's an inherent risk of injury. There's the painful physical injury to deal with, and then there's the psychological effects of sustaining injury, which can include things like being separated from your peers, low mood, mental health deterioration, weight gain, apprehension about returning to sport. Rehabilitation after injury is a difficult process. There's no current pathway or service available to rehabilitate children who present in the emergency department to get them back to sports or a pre-injury level. And this is a missed health opportunity to ensuring that young people continue to gain the health benefits of being engaged in sports. Recent application of the Ready Steady Go programme by the Dame Kelly Holmes Trust to some children attending Alderhay with chronic illnesses, for example, asthma, obesity or arthritis, has started. But the programme is delivered via Zoom and using an app, and it uses athlete mentors to help children along. It's not been specifically used in the context of rehabilitation post-injury. Also within Liverpool is a unique rehabilitation facility, R4P, which offers face-to-face sport rehabilitation post-injury to young people from the age of 13 years and older. The staff who run this facility have experience with working with elite athletes, and their programme of rehabilitation is mainly focused on adults, and it has not yet been demonstrated to be effective in young children. So my research question is, in young people who engage in organised sports who have sustained an injury, what programme of intervention is effective in rehabilitation back to active participation in sports? There are numerous barriers to get back into sports, and they're compounded in those from low income or marginalised group. Young people with lower socio-economic background and or from an ethnic minority are less likely to engage in sports for a start. They've got an increased risk of hospitalisation through injuries than those from a higher socio-economic background. And in order to engage in organised sports, money is often needed for equipment or travel or membership fees or something like that. And add on to that, the cost for rehabilitation, for example, travel to and from appointments, maybe time off school or time off work, This study will look to describe those attending the emergency department with injuries in terms of socio-economic status, ethnic background, and type of injury with a retrospective audit in the first instance. So the plan for the study is a retrospective description across the deprivation indices describing the patient journey in paediatric injuries and linking those with their health outcomes. Secondly is to explore feasibility of pathways and services by doing a prospective randomised feasibility study looking at standard care versus the Ready, Steady, Go programme and versus the R4P facility, and then a qualitative analysis of acceptability and engagement in the different programmes offered, asking staff, young people and parents and carers what they think. The prospective randomised study is going to look at young people aged 13 to 16 years old who engaged in organised sports, who present to the Alder Hey Emergency Department with an injury sustained through sport, which the treating clinician believes would benefit from a process of rehabilitation in order to return to sport. Exclusions include patients already in a programme of rehabilitation or those who have access to elite sporting academy facilities. Intervention and comparator is a summative evaluation of standard care versus the Ready, Steady, Go programme versus face-to-face R4P sessions fixed at 6 sessions per patient with 20 patients in each group. The outcomes, these will be stratified by socio-economic status, ethnic background, index of deprivation. The primary outcome will be return to sports at 9 months post-injury, and secondary outcomes will be things like PROMs, patient-reported outcome measures, time away from school, sports or work, adverse events, and cost effectiveness. Young people are central to this research, and their input into study design, interventions proposed, and how we communicate with them for follow-up will be sought by engaging in the Generation R YPAG group. A young person who has experienced injury will be asked to join the study group as a co-applicant. We are keen on ensuring that this study is offered to anybody who comes into the emergency department who fulfills the inclusion criteria, and that any exclusionary practices for recruiting into studies are eliminated as much as possible following such frameworks like the Include and the HIAT. Thank you very much, and I hope you enjoy your day.
Okay, so I hope this next item is fairly brief. So, as I said, we have to do our business plan as an ARC as a whole, and each theme has to do a brief summary of its business plan for this 18-month extension from October the 1st, 2024 to March the 30th, 2026. You saw on the slide that Dorcas showed in her talk that we have one of our sub-themes is cross-generational. At the moment, we don't have any specific work in that sub-theme, although they are contributing to the beach schools work in our research development network on seaside health and community well-being and health inequalities. And within that, the idea is that the beach schools would have a cross-generational element. My proposal as theme lead, and from discussions that we've had across the team, and I have communicated this to Professor Murray Lloyd-Williams, who's the lead for that sub-theme, and her colleague Cathy Montgomery, who I think is joining us online, is that we shift that to a cross-theme topic. So, as a whole life course is something that we're keen to look at in this theme, where we want to think about people or something across the life course, not just a part of the life course. I also thought it would be perhaps more useful if we could also have in our minds, is there a cross-generational element to this? Is there a potential here to bring different generations together, people at different stages of the life course into this, and how could we usefully bring them together into the same space as part of what we're trying to do? So my proposal is that rather than having it as a separate sub-theme, we have it as an overarching principle, what might be the cross-generational potential for this particular idea, this particular topic. And I just wondered if, very briefly, if anybody had any questions or any points, or don't you dare, or that's a good idea, and then we can move forward to deciding on that within our theme proposal. Silence isn't very helpful. Anyone think it's a bad idea? Do any of you think it might be a useful idea? Show of hands will do, please. Yeah, right, that looks pretty much unanimous to me, or certainly non-con. So thank you very much. We can now move on to... Can we do children and families, please, on the stage?
Hi, it's the Joe and Dorcas double X. So Dorcas and I are joint co-leads.
Okay, we go there.
Okay, good.
All right.
Joint co-leads for health and care across the life course. I'm the professional co-lead and Dorcas is my partner as public advisor. We've got two themes to touch on in this session. The first is domestic violence, which is going to be led by Dorcas, and then we're going to move on to a breastfeeding theme, which is also going to be led strongly by Dorcas, and I'm going to be the supporting act. So over to you, Dorcas.
Thank you so much, Joe. I love this topic. So I'm just going to give you a quick brief on the scope of the problem, which is worldwide. And you might say, here comes Dorcas again, domestic violence. The prevalence data from 2000 to 2018 across 161 countries found that worldwide nearly 1.3 or 30% of women have been subjected to physical and sexual violence. Research by WHO on behalf of United Nations Interagency Working Group on Violence Against Women, 9th of March, 2021. According to the crime survey for England and Wales, year ending March 2021, an estimated 5.5% of adults aged 16 to 17, 2.3 million people experienced domestic abuse last year. Isn't that a lot? Since the COVID, the domestic abuse has increased, and by the end of November 2020, the police recorded 206,492 domestic violence calls. By a year into the pandemic, November, 1.6 million women, 757,000 men had experienced domestic violence. So it has been noticed there is a major football match sometimes leads to domestic violence. Statistics in Merseyside, I would like to go into that, but the Commissioner of Police, they've just done a survey on the domestic abuse in Merseyside. And in Merseyside, 200 cases led to 175 charges last year, and 77% the year before. So what we want to do is just to look at this. I don't know if you all know Emily Sporro. She's Merseyside Police Crime Commissioner, and she has developed a strategy with delivery plan in partnership with many organizations working in partner to tackle violence against women and girls across Merseyside. And you can read that. There's a link to it. I haven't got the link in my paper here. What is the impact? There's a lot of impact on this. It's a national priority, and that is why F and Care Across Life course, we've been involved. I'm involved with it. And to work with all of us, we want to see how we can integrate families experience intimate violence and abuse. When this happens, it just doesn't happen to the woman or the man. It affects the children. When you look at it, it affects the children. and it affects the whole family, and that is why we have to make it a priority, and we're working with different people. There are a lot of initiatives in different places. In Plymouth, they've got what you call parent project, advocacy support for parents with learning disability that have been abused. And they call it Highway Trust, which they do. And what we want to know really is that this priority, we are aware of services in Merseyside, such as domestic violence, Merseyside domestic violence, and South Liverpool domestic violence. And I know about Savera, forced marriage. I know about Rasa, which is rape. But it's still increasing. Do we know of services which have implemented intervention on families? If you know any, just let me know. Do we have social workers working with acute trust, such as Alder Hospital, in relation to domestic abuse affecting children? The Vista project, we'd like to know what's happening within the Arc Northwest, if you have any idea.
Okay. Thank you so much, Dorcas. That's such an important area, and really is an example of an intervention which, well, of an experience which is truly cross-generational and highly pertinent to the work that we do.
Yeah. I just want to ask if anybody is aware of any initiatives, maybe online, that is happening across Merseyside. You can just send us a chat to us, and we can pick it up from there. I would like to know, because I've only mentioned 4 that I know, and as a midwife for 35 years, I know it does happen. The mothers won't talk about it. The BEM community will not talk about it. And it's how we can work together as family unit to support the children, not just the mother or the dad, to support it, to make it as a family unit. Thank you.
Thank you very much. So on everybody's desks, there should be voting forms, and on them, you're invited to indicate whether you think the themes that we're going to discuss over the next half an hour or so should be priorities, and secondly, whether or not you would like to take part. And I think there will be many different ways in which you could contribute. But perhaps one of the first ways, as Dorcas was saying, was really gathering a good understanding of what's already being done and how we can pull those together and work in close partnership.
So that's really important, because somebody left one on our desk at lunchtime, which is interesting because they hadn't heard the talks, but they already prioritised it. But they didn't leave any details, which is fine. It's not anonymous feedback, this. That's helpful, but not really helpful. Because what we need to know is, if you are interested in the project, we need to know how to get back to you and let you know what's happening, when the meetings are, how you can get involved. So please do, no one's going to come back to you and say, how dare you not like my project.
No.
It's just because we want to test the sense of engagement potentially in the different projects for this theme, know how to get back to people, and also to test what you are the Arc. It's not me, it's not Dorcas and Joe on our own. What you think is important, and how you feel you can support the work if you feel it's something you can work with. So please do put notes, but also an email or something, so we know how to get back to you.
Lovely. Thank you very much. So the next topic that we were going to raise is relation to breastfeeding.
Yeah, this one really is Infant Feeding Research Network. This is another network that we belong to, and it's led by Bethany Jill, University of Lancaster. And what we're looking for is what is out there. Where are we potentially looking at the low rates of breastfeeding? What elements of infant feeding will we be exploring? Is breastfeeding becoming a thing of the past? I'm throwing this question to you. You know, you might be a man and say, it's nothing to do with me. But anyway, you will have something to say about it. Breastfeeding is declining rapidly. And startling statistics prove that we need our voices and frustration to be heard to make changes. 1 in 200 UK women do not do any breastfeeding, after 0.5%. In Germany, 23% of women still breastfeeding. In USA, 27% in 1 year is still breastfeeding. But in Brazil, 56%. Now in Merseyside, St. Helens, 23.1%, is the fourth lowest in England after Knowsley. At Otterpool and Halton as well, they're very low. Sefton, 29.9%. Liverpool, where I come from, I'm disappointed as a midwife, 32.1%. And Wirra, 32.8%. New moms in Knowsley are the least likely in the country to breastfeed, and that's within North West Coast. Special attention is needed in policies designed to protect and support most vulnerable, such as babies born preterm. We've heard about neonatal unit before, or sick into the most disadvantaged families. Mothers suffering from poor mental health, they might not be able to breastfeed. We understand that. But if they have a support, they will. What impact does breastfeeding have on children? How can moms be supported to breastfeed their babies? Has obesity on the increase amongst infants and children? And I let Jo, because she works with them at all day.
Okay, just some from the chat, because you can't see it and I can.
Okay.
Sorry, I'm trying to help link up with the chat. So for the first question, I'm going to pass these to you, Dorcas. There's the Merseyside Violence and Reduction Partnership. Okay. That's one organisation. Okay. Another one here is LJMU have got the WHO Collaborating Centre for Violence Prevention. Okay. Professor Zara Quigg, so that's two for you.
Thank you. That's lovely.
So any others, put them on the chat, I'll pick them up.
Okay.
And Pippa Atkinson, who I can see, I think, has also written that her PhD, which is an art PhD, is on infant feeding and relationship building.
Okay, thanks. That's great. What we're trying to do with ACA is to bring families and children into the scope. We do a lot of elderlies as well and cross-generation, as Mark, and so we're trying to do more about families and children today. Do you want to talk about the obesity?
Well, I was going to bring a project which is in development from some of my colleagues at Alder Hay, being led by a colleague called Helena Kamarova. It's a study to try and understand why it is that healthy infants are admitted to hospital because of difficulties breastfeeding. And this isn't an uncommon scenario. My colleagues have done quite a lot of audit work looking at the number of babies that are admitted to hospital with concerns regarding infection, but in fact it turns out that they simply have difficulty breastfeeding and have become dehydrated, and etc. And of course that's a big problem, because not only is it a very stressful experience to have a baby admitted to hospital, but the baby is then exposed to the risk of infection. However careful we are in hospitals, admission poses a risk. And a significant number of babies that were admitted to hospital breastfeeding actually at discharge were on mixed feeding or fully formula fed. So their study initially was looking for partner organisations to do a prospective audit to really map out how significant the problem is across the patch and look for any trends in terms of groups of people that might be particularly susceptible to coming into hospital, and then to work with mothers to understand what support they were given with breastfeeding at the time of discharge, and then finally to develop an intervention which would be applied in the antenatal setting to try and increase people's confidence and reduce the number of admissions. So if you're interested in supporting that study, we'd be very grateful if you could indicate on your form if you think it's an important area. And my colleagues would also be very interested to hear if any of our partner organisations would be interested in taking part initially in mapping out the significance of the problem in their own centres, but then looking in the sort of developmental work as well, and finally the evaluation of an intervention. Thank you.
Thank you.
Okay.
Thank you.
I think that's the two questions that we brought. I can see hands in the air, so I think we've got questions for those topics or new topics.
Hi, I'm just wondering if you're aware of the government's breastfeeding initiative that the neonatal units are all a part of, where their aim is to become recognised as an institution that is advocates for breastfeeding, and our aim is for all mums, specifically on the neonatal unit and the maternity units, to go home breastfeeding, and they've dedicated nurses that we call breastfeeding nurses to support mum with that. I just wondered whether you're aware of that initiative, which is in line with the Family Integrated Care Initiative, where the parents are considered as part of the team that looks after their baby whilst they're in hospital.
Where are you based, please?
Lancashire Teaching Hospitals Trust is
Okay,
where I come from, but I'm working within the Arc at the moment.
Okay, thank you.
Follow that up.
Shall we follow it up?
Yeah.
If you can leave your contact details, we'll follow that up with you, because just thinking of time, but the question is how effective that is, and whether it's certainly worthwhile. I think the idea was think of a community-based intervention as well, but it's very important to know what the messages are and what the support is, and how that links into the community. There was one other, and I think we need to move on. Introduce yourself as well, sorry, please.
Hi, I'm Daba, Victor Public Advisor, African Global Voices. I've heard you mentioning domestic violence and some organizations and some grassroots lived experience which you work with. I was wondering that there is an organization which is called Freedom from Torture, meaning that why I mention this is that there's some pull and push factors into domestic violence. You could find out that the parents or the father or whoever is a victim of torture from where he's not recognizing it through PTSD. I was wondering if you could try and link those together so that it could sort of work from the grassroots level upwards. That's only a suggestion. Thank you.
Thank you so much, Victor. I'll be in touch with you, because I think the refugee group as well, they're doing something in relation to domestic violence and free from torture. So I'll be in touch with you.
Okay, can we move on then? Thank you very much.
Thank
Great
you.
session. Thank you. So there will be other ideas about children and families on the tables, which we will try and collate and then see. What we might do is circulate that back to this group. Oh, yeah, sorry. Use the mic, really. So we'll circulate some of the ideas that have been done on the tables around the group and get a sort of a thermometer of what people are interested in, and etc. So we'll pick that up. We got Paul's recording now. Paul is the adolescent sub-theme lead.
Hi everyone, my name's Paul Moran. I'm the lead with HCAL for the adolescent group. I'm just here to tell you about some recent activity in my portfolio. The first topic to pick up has been from the quarter has been a conversation with Health Junction, who are looking to bid for funds to create a wellbeing hub within Alderhay Hospital. There's been some evidence from interviews undertaken with parents and also health professionals, and that's identified the need for a service to provide a new integrated approach within the hospital. Health Junction have a tried and tested model that's being currently used widely in primary care, and with great success, and I'd like to bring one of those models into Alderhay. This supports the NHS's long-term plan to provide community-based approaches across the NHS, and being well isn't just about accessing health services, but it's also addressing things like loneliness, social isolation, addressing issues such as addictions or getting counselling or advice on welfare rights, and many other issues that you're able to participate in your local community. The Wellbeing Hub will be the central source for those families to be able to access whatever their needs are. The second thing that we've done in the last couple of months is we've spoken to Shahrukh, who I think has done a presentation today about a project looking to support sporty kids back to sport after a bad injury. As I say, I'm sure Shahrukh has done a great job in presenting kind of what the project is, but I just want to give you an example about why it's so important. I run a boxing club in my community, as many of you will know, and we've got some really talented kids. And one of the young lads we've worked with for the last 5 or 6 years, and since he was kind of, you know, right at the very beginning of senior school when he came to us. He actively boxed right across the country, and he's got, you know, had a great personality, really engaging, really supportive of the people around him, and came from quite a difficult background, but the positivity that he put into boxing really changed his life. Now, he got a really bad knee injury while boxing for the club. He attended hospital. He was put on a rehabilitation course to get him walking again, but that's kind of where it stopped. And he is at the moment kind of in a little bit of an in-between situation where he's not boxing competitively, and he's kind of found himself going down the wrong path. He's no longer got that structure of coming into the club, of exercise, and is pushing his boundaries, of having real goals to get to the Olympics, which is what all kids in amateur sport aspire to do. And he's kind of fell in with, you know, he's gone away from the positivity of our boxing club, and he's fell in with a gang in the local area. They obviously knew about his reputation in the ring, and you know, really kind of maybe groomed him a little bit, and took him down a bad path. He's been you know, arrested for selling drugs, enforcing, and becoming involved in a culture that, you know, is totally different from where he's been for the last kind of 5, 6, 7 years. Now, I'm not saying that this project was in place would have had any impact on any of these problems, but if he had a plan from day one to get him back to the level that he was at before, rather than just walking again, and he would have had some positive role models around him, talking to him about those future goals and steering him away from the paths that he took, then I think that would have made a massive difference. And I think Shahruk's project is absolutely brilliant. I'm pleased to say we have got him back under our wing now, and hopefully we're looking to kind of, you know, bring him into the fold for this project moving forward. But I'll hopefully come up with some positive news about this in the future. I've also been working with a project run by Courtney Franklin, who I think has been at Arcfest today. I hope some of you may have gone to the stall or the table that she's been at and spoke to Courtney about some of the work that she's been doing. Myself and Courtney worked together to write some questions for some interviews about why parents will bring children into A&E when the child has a temperature. We then reviewed the output of these sessions and built a framework that Courtney's using for future interviews. I think this is just a really good way of kind of utilising public advisors, giving our opinion, but also kind of being quite creative in what we're doing. I'm following the loop around as well, you know, being involved in the beginning of the process, being able to shape it, but then also kind of having a look at the detail that comes back from those interviews has been brilliant. So if you haven't had an opportunity to go and speak to Courtney before you go, please try and catch up with her if you can. Next, myself and Selena spoke to a group called Catch-22, County Lines Rescue Service, who are funded by the Home Office until 2025 and operate in 4 main areas. First ones being Merseyside, London, West Midlands and Greater Manchester. They work with young people up to the age of 25 that are at risk of exploitation through county lines. The young people are going to have a dedicated case support worker who will complete an assessment of the needs, goals, aspirations and development of a bespoke plan to support that young person. The young person will also look to reduce any other risk factors, support them exit their involvement. They have a dedicated mental health caseworker and women's and girls caseworker, and they also offer a rescue service between 9 a.m. in the morning and 10 in the evening, 7 days a week for people who have been found outside of their police force area in an exploitative situation. This tends to be from police custody, unfortunately, and you know they will help to return them to a safe place and offer ongoing support. I've obviously been talking with Catch-22. I'm really keen to bring them into the fold. They're going to have some great ideas about kind of, you know, how we can do research or start projects. And we're going to signpost into the Children at Risk workshop that Pete Dixon I know is looking to launch in July. And also, you know, have they got any ideas about research that we should be doing? So trying to kind of get them involved in the process as well. And finally, I've also spoken to the son of one of our colleagues. I think this is a great example about how we work together and how well we can work together. So I've spoken to the son of one of our colleagues in the Arc North West Coast about building a proposed business plan as part of his project in school. Now this just shows how kind of we work together, not only in our communities and our kind of academic groups and in our themes, but it just shows how we work together individually in our public advisor group as well. That not only helps people around us, but you know, as part of the family that I feel as though we're in. Thanks very much, everybody. If you've got any questions, I know we've got some people on site, but please feel free to contact me as well after the session. Good to speak to everybody, and hope you'll speak to you soon. Bye now.
Please do use the feedback sheet for the topics he was talking about. I'm aware that my older daughter was involved in a project in Scotland linked to that, which was two of these projects, which is exploitation of sports people being offered drugs for performance, and education around the pressure they can be put under, which the Scottish Police Service pulled together an education package for coaches and young people to prevent them falling into that trap of this will only help a bit and nobody will know sort of thing. So there are other things around that we could pick up on. So please do that. So the next one, I think it's you, Kathy, isn't it? So can I introduce Professor Kathy Montgomery from LJMU, who is, am I right?
We were going to do the health junction, I think next.
I am here. Can you hear me?
We'll do that one first. So Kathy Montgomery's our vulnerable, marginalised groups lead.
Hi. Can everyone hear me okay in the room? Yes. I'm not getting any feedback.
Yes, we can hear you. Yes.
Oh, brilliant. Okay. Yeah, so I just wanted to give a brief update on what we've been up to, different bids we've submitted, and kind of what we've got in the pipeline. So thanks for sharing the slides. I can't see an option how to share them here. So since the last sub-theme meeting, which I couldn't attend, we've submitted a number of bids on maternal drinking and support for mums who want to reduce their drinking. They're led by Dr. Abby Rose, and I know Abby's been in touch with the ARC about support for the bids and also getting public advisors on board to help with that. So she's got through to stage 2 on the NIHR Research for Patient Benefit Scheme, and she's waiting to hear back from that, hopefully in the next month or so, about taking that forward. We're still preparing the bids for the NIHR for the primary care assertive outreach team for people with alcohol dependence, so to really target people who are in areas of very low socioeconomic status, to try and get them into treatment earlier on so that we can reduce the alcohol burden on the NHS. With the ARC, we also made a bid to the Mental Health Improvement Network Project 3 strand, and that was led by Paul Richardson and Lynn Owens in the alcohol care team, and the team at the ARC, really for trialling an assertive outreach pathway for people with alcohol-related brain injury. Unfortunately, that bid was unsuccessful, but we have got more projects in the pipeline with the alcohol care team that we're currently developing. We also recently submitted a bid to Innovate UK for the Office for Life Sciences Addiction Mission Call. This initial call was aimed at reducing drug-related deaths, and there had to be an innovation element to what we were doing. So we developed a project with the ARC as our testbed research partner, where we've been looking at repurposing low-cost wearables to try and identify people who are particularly at risk of drug-related death, so people who've recently finished a period of imprisonment or incarceration, or couple who have recently completed a residential detox and rehabilitation programme. We know they're at very high risk for relapse and drug-related death due to loss of tolerance. So we submitted a project with the Arcfest on that, and we expect the outcome on Friday this week. So we're hopeful to get that initial funding, and then that opens up really the scope for the larger funding from the addiction mission, which has just been announced for the closing date in the middle of July. One of the projects I'm going to talk about today as well is that we've secured funding from a vaccine manufacturer based in Liverpool called CSL Seqirus, and they manufacture a lot of the flu vaccines for the UK, and that's a project that's going to look at investigating flu vaccine hesitancy, particularly in marginalised groups. So how can we support areas of lower socioeconomic status, different ethnicities, people who use substances? How can we develop public health messaging for these groups which could promote positive health messaging and increase vaccine uptake in these groups to reduce the burden of the winter influenza response in Liverpool City region. So that project that's funded by Seqirus was the one that I wanted to talk a little bit about initially. If you could click on to the next slide, whoever's looking at the slides. So the project that we pitched, and the reason why we kind of looked at vaccine uptake in different types of marginalised groups. So we know people who don't necessarily engage with primary care, like people who use substances, people who have people in areas of very low socioeconomic status, and people who are ethnically diverse are much less likely to take up the winter influenza vaccines. So uptake is much lower in ethnically diverse and ethnically white patients for those aged over 65, and those clinically at risk as well. So this isn't just an effect of old age, although there seems to be increase in that age group, but it's also in those clinically at risk. And while I've not presented the data here, we've received the data for all age groups from the business intelligence team in Liverpool Integrated Care Board, and we can see this pattern across all age groups, even though there's not necessarily as big a drive to vaccinate healthy younger individuals. The uptake is much lower in those who are ethnically diverse rather than those who are ethnically white. One of the problems recently, especially in the last couple of years, is that people are getting booster fatigue. So we've all been pushed towards getting vaccinated against COVID, and then when the seasonal influenza vaccination programs come along, the thought of getting more vaccinations or having to make another trip to your GP, and the kind of the urgency of the necessity of these type of programs has been lost a little bit with the COVID-19 response. There are also a lot of cultural and religious factors which could inhibit engagement with an uptake of vaccination. So the Liverpool Vaccine Equity Project, which was run by Miriam Teitmeyer from Liverpool School of Tropical Medicine, really looked at community asset-based responses to COVID-19 vaccination and how we can embed community champions to allow us to get over a lot of cultural and religious factors. So what our project is really going to do is build on that understanding to explore influenza vaccine hesitancy and support enhanced vaccination uptake in marginalised groups living in the UK. And one of the reasons why this is important is it doesn't just really feed into the health messaging for influenza vaccine hesitancy, although that's what we're primarily interested in. This could really, if there was to be another pandemic, another immediate health threat like a nuclear disaster, it could feed into the types of messaging that we use in marginalised groups for all of this range of possible disasters that could occur. And don't panic anyone within the next, years to decades. So outside the area of influenza vaccine, this is also important that we understand the different types of health messaging that work in different groups, and we're ready to activate those if we go from peacetime to wartime. Next slide, please. So the project that we're doing with CSL Seqirus, which is where we'd really like to seek public advisors to come on the steering group for our grant and to be involved in the work. Phase one is a scoping review, mapping all of the literature on health profiles existing best practice and lessons learned from the COVID-19 pandemic. And that's where we're looking at the GP level data from across the Liverpool City region to understand, based on the population profile of each GP, if there are lower levels of particular demographics being vaccinated within particular pockets of Liverpool. So essentially it's really so that we know where we can target the rest of our work in terms of recruitment of both healthcare practitioners and also patient experts and patient participants. Phase 2 is a large qualitative research phase informed by our review, and there'll be a lot of peer-led focus groups and peer-led interviews with communities and individuals across the Liverpool City region, as well as semi-structured interviews with regional and national health policy stakeholders. And then phase 3 is triangulation of these results according to the behaviour change wheel. Qualitative data and themes will be interpreted in line with the COM-B model behaviour change, and we'll develop then public health messaging and intervention and content based on the interviews that we've had with those stakeholders, policymakers and healthcare practitioners. After we've triangulated these, it would then be hoped that we have an intervention that we're ready for trialling in primary care in the Liverpool City region, but also that we would then incorporate this into the teaching that we do of the vaccinators in Liverpool. So in LGMU we obviously have a very large nursing programme cohorts. In the University of Liverpool, similarly, there's large medical cohorts that we would then try and incorporate a lot of this learning really and knowledge exchange into these programmes to influence the winter flu response really at the grassroots level when people are being taught about the health communication with these different populations. So that was really all I had to give on my update, Mark. I don't know if you want me to take questions on this now.
If there are any, yes please, but I think Jo also wanted to raise something in this topic area, which I think she sent you an email about. So any questions for Kathy? No, it looks like you've explained that very thoroughly, and so please use the voting forms, give your feedback, and if you're interested in helping Kathy, particularly with the vaccine, I'm sure there'll be some practices around that be interested in looking at that too, particularly in those areas. Maybe talk to the local medical committee if you haven't yet, and let them know what you're doing and see what feedback you get from them. I can help you do that in Liverpool area.
Jo, did you want me to start with leading the discussion, or did you want to?
Yeah, if you lead, Kathy, that would be great. Thank you.
Brilliant. Okay, so I had a conversation with Jo, and we had a discussion really about how adverse childhood experiences, in particular, can affect trajectories for children of substance users. When we talk about adverse childhood experiences, it's really anything that could have caused stress or changes to your social learning in the early stages of life, which would then predispose to a certain behaviour occurring in the future. Adverse childhood experiences can result in a range of adverse outcomes for those children once they become adults. So, for example, the children of substance users are much more likely to go on to use substances themselves. And there are a number of, and there's probably a lot of public advisors here who might not have the specialist knowledge in this area, but a number of reasons for this. So some of these are neurochemically based. So as the developing brain comes under enhanced stress, this can cause changes in the stress response in the developing brain, which are also there during adulthood. So when you're then exposed to stress as an adult, your brain responds differently, and you might give increased salience to substance-related cues or other sensation-seeking activities and risky behaviours. Now, at present, substance use can be very much cross-generational, multi-generational. So, for example, if you take a child who is in a substance-using family where their parents are substance users, the parents might not seek treatment for their substance use, and the children live in this family for a long period of time. And this becomes the norm for the children. As those children grow up and become parents themselves, you then have a grandparent, a parent, and some more children living in that house who might all be exposed to this type of behaviour. In the UK at present, there is only one service that targets substance use as in a family treatment setting, whereby the children, the families, grandparents can all live in the same setting. And this is really a trial by the Scottish Government, who have very high levels of drug-related death. It's kind of a family-based therapeutic community. The trial, obviously, because of the nature and the resource involved in it, has room or capacity to take 20 families in total. And the trial's only running for a year at present. So I think what Joe and I would like to discuss with you is their interest in developing research which allows us to understand how we can engage families who are involved in multi-generational substance use, how we can understand and provide support for these families at an earlier stage, so you don't necessarily have, for want of a better term, history repeating itself, and the children of substance-using families really being in this repeated cycle of being drawn into substance use when they return to their families. How can we really, I guess, develop a community of change where we're embedding these community champions in these types of areas where the support is there for families. And also, just to bring up, I think particularly for women, this is a really big problem, because if you're a female substance user who would like to seek treatment for your substance use and you have children, there is the chance that your children will be taken into care, and this is always then further marginalising female substance users. So it's really, how do we understand these processes and how do we put support in place for these families earlier on, so we don't end up with repeated substance use in families. Sorry, Joe, I don't know if you'd like to take over there. I probably miscommunicated what you were telling me very, very badly. So
Not at all.
To rephrase anything I said.
Not at all, Cathy. You explained it beautifully and very much better than I would be able to myself. So thank you very much. It's a conversation Cathy and I have just started to have, but it seems to be a very important theme, and again, picks up the theme of sort of cross-generational research in health inequalities and disadvantage. So I hope Cathy and I will continue to have a conversation around this possible area of research. But if there are people in the audience who would like to be involved, or know of partners that might want to be involved, would be delighted to learn of any potential collaborators or people with experience that would like to join us in this area.
So Prestwich has a drugs library for substance misuse researchers, and I think they include advocates. So a lot of community drug services will have advocates, and sometimes those advocates go around and do education. These are the mistakes I made, this is what happened to me. So that might be a group to tap into to see if there's some sort of community level, school level or whatever intervention that could start to help signpost people where they might be able to go and access help, but done then what you're saying is at the family level. So from my work in that field, that's where I think one opportunity might be, that there are people who have got that background and that confidence in telling their story. I've certainly worked, unfortunately he committed suicide, but someone I've worked with for many years as ex-drug user and drug user and advocate, used to come and do training for healthcare professionals, postgraduate healthcare professionals, on his life story, which he found very gratifying for him, but also the people listening to his story got a much more in-depth understanding of the complexity of the world that leads you to be a lifelong drug user. So yeah, I think that's one option. Anybody else aware of any opportunities, any innovation, any interventions anybody's aware of in this field? Okay, well, we can pick it up. Again, please use your forms. And then I think it's me. So I'm working age adult life course sub-theme lead, and the vast majority of work that would come under that heading is external studies looking at adult health. So the long COVID study, etc. There are quite a number of trials that we support that would come under that heading. But I've got two things. I've got Rob MacDonald and Ben Fatimilehin are going to do brief presentations on ideas they've got. But also, please do use your forms to let me know if you're in a health or social care organisation, provider, commissioner, who's involved in workforce development. Remember I read earlier out the national research initiatives that the department, our minister's very keen that we focus on. One of them is workforce development and retention. So the ARCs are very keen, and it would probably be through this sub-theme, to think about doing collaborative work across different organisations about what approaches are being used to retain the workforce, to train the workforce, to talk about multi-skilling, people shifting the way that they work, looking at organisational culture. So anything like that, please put something on the form and how we can contact you or get back to you about that and see if we can pull together a small group to start to pull together over the next 6 to 12 months one or two projects under that heading. I think it would probably be sensible we set up a research development network on workforce. So, I don't know, is it Rob first or Ben first? Is yours pre-recorded? Yes, so can we start with Rob's pre-recorded? And then Ben, I'll let you be the wind-up man. Get the party going home dancing.
My name is Robert MacDonald, Dr. Robert MacDonald. I'm a retired architect and a former reader in architecture at a university. I also am a volunteer at Merseycare and I teach art for well-being. So if you could please show the first slide. So I'm bipolar, and that's probably the main reason I got involved with Merseycare as a service user. This is my visual representation of bipolar, the manic and the euphoric sides of the episodes. The manic episodes can be very frightening, and the euphoric episodes can be very creative. So I bring these skills to the Art for Wellbeing class. Thank you. I recently joined an art or drawing for beginners class in Waterloo in Liverpool. And the first exercise we were asked to do was to draw a selfie. This is my selfie drawn in a fairly manic state of mind. The restriction was that we had to keep the pencil on the paper when we made the drawing. I would encourage everybody to try to draw their own selfie with a pencil, but don't take the pencil off the paper. Next slide, please. Working with a group of between 6 to 10 people in the Southport and the Walton and the Bootle Life rooms, we studied different artists, and in this case it was Picasso and his Minotaur, who lived in a labyrinth in Crete. And each member of the group made a collage of a face, which was their interpretation of the Minotaur. And the life rooms are drop-in centres for people in different stages of mental recovery and with different challenges. Next slide, please. And finally, we work in a co-production way, sitting side by side, working together, talking about art and culture and making our own interpretations and creations. Thank you very much for listening, and I hope you enjoy the presentation.
And I guess for our purposes, it's to see whether we think that this is something to talk to life rooms about whether we should be doing, or how we could help them do an evaluation of this particular approach. We've already had something earlier. She's gone. No, about performance and health, and this could be an opportunity to talk about other ways of using art as a therapeutic way. And I'm aware that there's a group at Edge Hill. There's a professor there who looks at art therapy. So there is a group of academics who do work in this field within the ARC. So thanks very much. Anything you want to add briefly, Rob, before we move on to Ben? Or was that, have I sort of covered what you wanted to say?
Thanks very much for listening, and to encourage everybody, don't be frightened of drawing.
No.
I get the kind of response, I can't draw. The last time I drew was when I was in primary school. But that's not true. I don't think you should be frightened. Drawing is a very creative activity, and I think everybody should be encouraged to have a go at drawing.
You got the mic? There's one. No, he's done. Do one quick question here, and then we'll move on to Ben.
Can I ask a question to Rob, please? I've got a friend with who lives in Formby with fibromyalgia and ME, and she really loves art necessarily, but then sometimes it's hard for her to go to commute to Southport Life Rooms because of her condition, etc. Is there any way the Life Rooms could come out to her or come out to these people with fibromyalgia and ME and be able to do some home activities in terms of getting them involved in art and drawing and culture, because it will help them a lot, a great deal.
Yeah, I think that's a fantastic suggestion, that, you know, we take all the things that we're doing, all of us, not just the artists, but the researchers, to the houses, to the places where people live. And I think that's a wonderful suggestion. And I will take your proposal back to some of the learning facilities in the life rooms and see what response we get. But I think that idea of doing research in a person's house or dwelling is a very provocative idea and very progressive. Thank you.
Ben, do you want to come and sit up here and present?
So I'm Ben Fatimale, I'm Regional Social Prescribing Advisor for Physical Activity in the North West. I'm hosted by Active Lancashire, and I've been considering alongside a number of stakeholders the integration of physical activity with social prescribing. And so I'm hoping that the benefits of physical activity are well known, but there is a wide range of benefits in terms of reducing the risks of a variety of sort of conditions, and including sort of depression as well, and then improving social connectedness. So we wanted to look at the sort of typical commonplace social prescribing pathways and work out how well currently physical activity is integrated into social prescribing. So we focused initially on where the bulk of the work sort of takes place, which is social prescription, and also providers. So asking a number of key questions, but given the length, I'll just skip forward. So we actually spoke to 154 link workers across the North West. We did the provider survey, which is over 200 providers, and this fed into our results. And I'll just give you a few highlights from the social prescribing survey, in which we utilised the COM-B model again, just to ensure that link workers had the capability, opportunity and motivation to actually make referrals into physical activity. So link workers' awareness concerning the benefits of physical activity. We found that there was broad appreciation and valuing of the benefits that physical activity could bring to their clients, and this stretched right across those benefits there. And it's just worth mentioning that there's huge inequalities around physical activity, with quite large proportions of society completely inactive, and some of those groups that are disadvantaged in that way are sort of BAME groups, those with long-term health conditions, women, and also those living in deprived areas. But the link workers themselves seem to appreciate the value physical activity could play in their roles. And in fact, physical activity was in greatest demand amongst the cohort and the sample that we spoke to. 44% of that 154 link workers advised that they felt there was a provision gap and that they would like to see more physical activity provision. So there was a number of things that could help link workers themselves in terms of their capability, and we looked at sort of their knowledge confidence across this, and here it seemed as though meaningful learning was derived from the link workers being physically active themselves and their experience and familiarisation with physical activity. There is formal sort of training out there that link workers can go on, and that appeared to have some sort of benefit for the link workers, as well as looking at collaboration between stakeholders, so collaboration between, say, leisure centres and link workers, physical activity providers, sports clubs and social prescribers as well. And the good news was that when it came to the actual provision itself, link workers seemed to indicate that the things that would be of greatest benefit, most broadly across the group, were that, just if I can read that, beginners and sessional group, and this takes care of, we did some triangulation across both reports, and this takes care of one of the challenges that the providers themselves raised, which was about the levels of fitness amongst the referrals. Then a free taster session cost again came out in both reports, so again some sort of addressing of cost, and then a buddy system, and there was something that came up in both reports again about the welcome, flexibility of options, personalisation, that sort of thing. And so what was good about this is that these things are non-specialist, so hopefully the idea is that they'd be relatively easy to help to evolve physical activity provision and make it social prescribing ready. So the main reasons for workers receive referrals, and this was looking at opportunities in terms of the context of the role. So what is the perceived function of a social prescriber's role? And here you can see, you know, they're getting referrals around loneliness, stress, anxiety, depression. Less than one in 5 are getting referrals around physical health. So with all those benefits you can get from being physically active, quite a large majority are not able to access that through social prescribing at the moment. So, and then the outcome link workers are measured on, and again this idea of what is the perceived role of a social prescriber, does that need to change at all to incorporate physical activity into that, given the benefits it can bring? And again, if you look at physical health there, and also I think there's physical activity over on the far side, less than 1 in 5 again are saying there that they are actually measuring levels of physical activity or physical health. So in terms of motivation, the link workers appear to value and appreciate the benefits that physical activity can bring, so it doesn't appear that we've got some issues with motivation there. Capability, yes, there's some requirements in terms of knowledge, confidence, and maybe getting link workers themselves more active, because they seem to be less active than the general population in the northwest. And then finally, and this is of most interest, and this is possibly where some of these questions now come up, does the link worker context support physical activity referrals? How does the role need to include the physical activity focus? How does the physical activity sector need to evolve to sort of be social prescribing ready to receive those referrals? And is that specific to social prescribing, or is that more a question of making it more inclusive, so those inactive individuals who at the moment seem to be excluded from physical activity can get on board? And then finally, what is the role for the link worker in the physical activity sector's evolution? And something that Mark sort of anticipated very nicely, a second phase of a pilot we're looking at, actually does look about this, I don't know how many of you have heard of Pivot to Wellness that's happening across leisure centres, where they're sort of, a number of them now are moving towards being wellness centres and having a range of services that operate from them, you know, right the way around in quite holistic health and early intervention and prevention. Thank you very much.
Thank you very much.